Hi, my name is Becky Clarkson and I'm Director of the Continence Research Unit at the University of Pittsburgh. Today I'm going to tell you about the brain changes associated with treatment of urgency urinary incontinence with onabotulinumtoxinA. Here are our disclosures. We've been using therapeutic probes to understand the brain's loss of control of the bladder in urgency incontinence. We've previously used pelvic floor muscle therapy to probe brain changes when women with urgency incontinence are retrained to deal with urgency. Here, we present the brain changes associated with the bladder-based therapy, Botox therapy, which we propose reduces sensory signals to the brain rather than addressing the brain's role in control of continence. Our main regions of interest within the brain are derived from previous studies defining the working model of brain-bladder control. They are the medial prefrontal cortex, which is responsible for executive control of voiding, the dorsal anterior cingulate cortex and supplementary motor area, which are responsible for pelvic floor muscle control and urgency suppression, and the right insula, which is the seat of visceral sensation. We recruited 20 women over the age of 60 who are undergoing onabotulinumtoxinA treatment for non-neurogenic overactive bladder. We conducted an incontinence evaluation and functional MRI before and 6 weeks after treatment. We conducted a provocation of urinary urgency using incremental infusion and withdrawal of fluid into a full bladder. And we used a contrast of brain activity during infusion and withdrawal, which has been standard as an urgency provocation tool in fMRI for a number of our previous studies. We defined responders as those with 50% or greater decrease in the number of leaks per day on a bladder diary. Out of the whole group of 20, we had 13 responders and 7 non-responders. There was no significant difference in age, number of leaks, number of voids per day, or MRI bladder volume at baseline between responders and non-responders, but there were significant differences using a paired t-test pre-post at p less than 0.05. When we looked at our regions of interest, we found clusters within our a priori selected regions of interest with significant change in activity after Botox therapy at p less than 0.05 uncorrected with a 16 voxel threshold. Within the whole group, we found 2 small clusters where there was decreased activity in the right insula. When we looked at the subgroups of responders and non-responders, we found in responders 3 small clusters with a decrease of activity in the anterior cingulate cortex and motor area, and we found 1 very large cluster of decreased activity in the right insula. In the group of non-responders, we found increases in activity in these 2 areas. So there were 2 clusters in the motor area and 1 large cluster with increased activity after therapy in the right insula. So when we looked at the whole group, there was a slight decrease in insular activity after treatment, which was likely due to the reduced afferent activity after Botox treatment. When we separated these into responders and looked at those specifically, we found a very large cluster of decreased activity in the insula. And this is likely due to much decreased afferent activity after successful Botox treatment. We also found decreased activity in the motor area, which is likely due to the decreased need to control urgency due to the decreased afferent sensation. In the group of non-responders, we found a large cluster of increased activity in the insula, and we also found a small amount of increased activity in the motor area. And we don't have a good explanation for this, but we think this is potentially due to a slightly larger bladder volume during MRI testing, which caused greater sensation in the bladder. In conclusion, there are changes in the brain's reaction to urgency provocation after treatment with onabotulinumtoxinA. We found changes in the a priori regions of interest, which were as expected in the responder group. We found a reduced activity in the insula, which was likely due to reduced afferent activity. We found reduced activity in the motor area, which is likely due to reduced urgency. And we found no change in the executive control area. And this was probably because the treatment was a peripheral treatment of the bladder and was not behaviour-based and was not trying to change the brain's control of the bladder. The changes in non-responders were unexpected, but potentially due to large bladder volume without the benefit of treatment relief.